Welcome back to this episode of Tubules Live. Today we're very lucky to have Dr. Daniel Flynn with us. Daniel qualified from Trinity College in Dublin in 2002 and thereafter completed a 3-year specialty training programme in endodontics at the Eastman Dental Institute. He's passionate about learning and teaching and carries out a number of hands-on courses both in the UK and internationally. He's also very interested in online learning and has done a number of CPD and online programmes in association with dentinal tubules. So today's topic is, implant is my backup option, but endodontic microsurgery really works. So without further ado, I'd now like to hand over the floor to Dr. Daniel Flynn. Thank you.
Hello, good evening, and welcome to Dentinal's Tubules. I'm Daniel Flynn. So today we're going to talk about implant is my backup option, but endodontic microsurgery really works. And I'd like to share what we are doing in practice and the developments that have come in endodontics over the last 10 years. So as an undergraduate student, I really didn't like endodontics, and it's taken me a while to develop a love for this subject. I felt, as with an undergrad student, we were taught everything is stainless steel files. Everything felt very slow and laborious. But there's been a revolution in the technology of endodontics in the last 10 years. One of the first developments that really got me involved in endodontics was the microscope. And with the visualization that we could see, this really led to an interest in finding more about this subject and how we could produce better clinical results for our patients. So I'm going to show some cases today, and I'm going to discuss all the different options. Endodontics now has become really predictable. The classical kind of view of endodontics, and especially retreatments and endodontic surgery, was that it didn't work very well. Now that we've got the benefit of all the added technology, we're seeing a massive increase in our success rates, and these now have all become really predictable. So let's start with our first case that we're going to discuss. So a 30-year-old male presented with a double abutted bridge from his upper left 4, upper left 3, all across to the upper right 3 and 4. So he lost his upper central and lateral incisors during an accident skiing as a teenager. Now this prosthetic work has lasted very well, so that has all been in place, but he's a biological failure. So in radiographic examination, we find that there's apical periodontitis associated with the upper left 4, there's apical periodontitis on the upper right 3 and the upper right 4. Now, because they're all connected via a long span bridge, to dismantle this tooth and put it all together is going to be very costly. To extract the teeth and to do a denture is against the patient's wishes, and he's obviously not going to be happy with a gap. So we need to find a fixed solution for this patient, and we need to be able to give him the treatment options that are available. So we can look at this from a restorative point of view. So how are we going to be able to mechanically reproduce the restoration that's there? And then we also need to look at it biologically. So the patient is having pain and swelling from the upper right and from the upper left. The main swelling is on the upper right hand side. So from the radiographs here, we can see that there's a technically inadequate root canal treatment associated with the upper right 3 and the upper right 4. And on the upper left-hand side, there's a technically inadequate root canal treatment there. So what are the options available? So from an implant point of view, we can either section the bridge from the canine to the canine and place 2 or 4 implants in place of the missing teeth. Then we have to decide if we're going to accept the 3 and the 4 on either side, or whether we're going to extract and place them with implants as well. So there's many decisions, and as we've done these cases in courses, we'll get many different options on what the students would like to do. From an endodontic point of view, we can dismantle the crowns, we can take the posts out, and we can redo the root canal treatments. So we need to be able to present all this information to a patient in a logical manner so that they can come and decide what is the best treatment option for them. So let's focus first of all on the endodontic options. So we can dismantle and treat. So we can remove the crowns, remove the posts, take out the paste or root filling material that's in the actual canals, and build the teeth back up again. Now we can use the same prosthetic design that's been there previously, or we can make a bridge from the canine to canine and do the 4s as individual units. Now, why has endodontic microsurgery got such a bad reputation? Now here we have a couple of examples of cases that have been done from years previously. This is hopefully the past. In the first radiograph, we can see that there's copious amounts of amalgam. There's more amalgam in the tissues than actually in the tooth. And a lot of the problems with the past was there was a lack of understanding of the actual cause of the disease. As endodontists, we're trained to think biologically. So we're always, every single case that we examine, we look, what is the cause for the disease? In these cases, there's no root canal treatment presence beyond the posts. And the treatment option that has been taken is that 3 millimeters of the tip of the roots have been cut off and some amalgam has been plugged in to the top of the root. Now, biologically, this was never going to work. We can see on the second photograph here, the unsightly scar tissues that were used. And often there was just straight line incisions or semilunar incisions made. And these were stitched back together, but they always resulted in scar tissue. The third example is a tooth where there's been apical surgery done on a tooth that has no initial root canal treatment. And this again, we have to think biologically, is this going to work in the long term? The fourth example here is a case that has had 3 previous apicectomies completed. Now, the problem with apicectomies in the past was often that you weren't able to see exactly what you were trying to do.